My purpose is to present a few lectures on vomiting. It's basically going to be broken down into 4 parts. One is I'm going to consider actually what vomit is, and that's what we're going to be doing this lecture. Then we're going to be going into the mechanics of vomiting, what actually happens in your body when you're ejecting the contents of your stomach outward. And then I'm going to be dealing with the neurobiology of emesis or vomiting. And then finally, the final lecture, I'll be going over some basic pharmacological concepts in terms of how antiemetics work. One of the things that I'm going to be doing is pointing out vocabulary. And so I want to first start off with the notion vomiting and emesis. They mean the same thing. So I'm going to be going back and forth employing those terms, vomiting and emesis, to get you used to being comfortable with either one of those terms. So I guess first up is, what is vomit? Well, I think we all kind of have a basic idea of what vomit is. It's whatever's in your stomach. So what's in your stomach? Well, typically food. So whatever you're vomiting is going to have a lot to do with what you have recently eaten. But there are other contents in vomit that may or may not surprise you in addition to food, and so I want to walk through those. One of the things is saliva. Our body makes saliva. Most of the saliva in our mouth is produced by either the parotid gland, which is a big gland on the side of your face, or I have some saliva glands in the floor of my mouth. They all work together, pushing saliva into your mouth for digestion, because saliva is the first part of the digestive process. What you may not be aware of is how much saliva we make. And typically a person will make 1 to 2 liters of saliva per day. So let's go ahead and write that out. 1 to 2 liters of saliva every day. Well, that's a fair amount of saliva. So where does that saliva go? Well, we swallow it. So we're constantly putting in a fair amount of saliva into our stomach. So when we vomit or when we undergo emesis, then the saliva in our stomach is going to be a part, along with the food contents, that's going to be coming out. Another thing that we're going to find in vomit is going to be mucus, because mucus is in the stomach. Mucus made from specialized cells that line the GI tract, and in this case the stomach. We need the mucus there because the interior regions of the stomach is very acidic. And the major acid in our stomach is going to be hydrochloric acid. And the pH is around 1.8, which is fairly acidic. The acid is there because it's very good at breaking down food contents. So the whole point of course, having food in the stomach is so that the acid works on it, breaks it down, putting it in a form where the rest of my GI tract can absorb it. Well, the reason acid is very good at breaking down food is the very reason that I have to have some type of protection in my stomach so that the acid doesn't digest my own stomach. And so you have specialized cells in there that create mucus to coat or to line the stomach so that the acid doesn't digest itself or doesn't digest the stomach, and the acid can do its job on the food without hurting the stomach. Well, because you have all of that, mucus is going to be part of what's coming up when you eject the gastric contents out of your stomach. Another thing that you're going to be possibly finding in stomach or in vomit is going to be bile. Now, I want to take a couple of minutes and talk about bile. Bile is made by the liver. So let's just draw this over here, made by liver. And it is stored in the gallbladder. It sits in the gallbladder until the appropriate time where the gallbladder will contract and actually push the bile into the very first region of our small bowel or small intestine. And so that first region is called the duodenum. a very short region, but it's the first part of our small intestine. So what you have is you have stomach contents going to go from the stomach into the duodenum through another structure called the pyloric valve. And the pyloric valve separates stomach from the duodenum. So at the appropriate time during the digestive process, the pyloric valve is going to relax, allowing the contents of the stomach to go into the duodenum. And then at that time, the gallbladder is going to contract and is going to push bile into the duodenum. So what does the bile do? The job of bile is to break down fats. And so ultimately, what I want to do is I want to convert fat into fatty acids. So bile is a part of that process, because when I convert it to fatty acids, then that puts it in a form that my GI tract can absorb. So bile plays a very, very important role in the digestion of fats. So what happens, though, and this is not that uncommon, that you can have bile reflux. And what that means is that bile goes from the duodenum through the pyloric valve back into the stomach. It's not that uncommon for us to have a little bit of bile in our stomach or to have a little bit of bile reflux. So if there is any bile in the stomach, bile has a yellow to green look to it. And maybe you've had this experience of vomiting and having some greenish or yellowish to it. Probably is a little bit of bile in your stomach. And again, that's fairly typical. Now, if you have significant bile reflux, which is a pathology, large quantities of bile can actually irritate the stomach and cause gastritis. And the gastritis itself could cause nausea and vomiting. So too much bile actually is going to cause nausea and vomiting anyway, but a little bit of bile is not that abnormal. So I think what I want to do is to, at this point, give you a sense of where things are in terms of anatomy. So let's go ahead and go to a drawing that you're all familiar with, I'm sure. We've all seen these in terms of our digestive tract. So let's label a couple of things. Obviously, you have the mouth. You have the esophagus. The esophagus is where your food goes when you eat it. It goes down to the stomach. And so what I want to do is let's go ahead and label some of these parts, because I'm going to be referring to these things in future lectures in this little series. So the first thing I'm going to point out is the cardia of the stomach. And so that area right there, we're going to go cardia. Of stomach. And the cardia of the stomach is that first part of the stomach, and actually in the cardia of the stomach is located a functional sphincter. And I call it a functional sphincter because the anatomy, if you were to look at the anatomical structure, it doesn't look like a sphincter because you don't have these large circular smooth muscles that are obviously a sphincter. But the smooth muscles are arranged where it does function as a sphincter. And of course, its job is once content of food goes into the stomach through the esophagus, you don't want the contents of the stomach to go back up into the esophagus. We would call that acid reflux. So it's basically its job is to keep the contents of the stomach in the stomach. This functional sphincter is rather weak, which is why some of us have acid reflux, but still it's a sphincter nonetheless. The first part of the stomach, I'll go to a different color here. So this region here, we're going to call this the fundus of the stomach. It's the top region. I'm just going to say fundus, but it's fundus of the stomach. And then down below the other end, and I'm just going to go right there, that's going to be my pyloric valve. And unlike the cardia or the functional sphincter of the cardia, the pyloric valve is a sphincter. It is a well-developed anatomical sphincter. A lot of circular, smooth muscle, and it's a very strong sphincter, and it's a very strong valve. And of course, looking at it, you would guess its function, which is to keep the contents of the duodenum from going into the stomach, but also to hold the content of the stomach, keeping it from going into the duodenum until the appropriate time. Because again, food has to sit in the stomach and allow all that acid to do its job. So speaking of such, here is the duodenum. There, so at your first part of your small bowel. And we have another region that I'm going to be referring to, and we're just going to go this region here, and that's going to be called the antrum of the stomach. And then lastly, and I'm just going to go broad here, the middle part of the stomach I'm just going to call body. Now, following this on through, let's go for some other vocabulary here. Obviously, you have your liver, you have your gallbladder here. It's tucked up behind the liver, you see. And you can see the continuity. You see the gallbladder continuity going through and then can go into the duodenum there. And so that's where, again, the bile is being produced. Of course, we have the pancreas here. It is also going to be pushing its digestive enzymes into the duodenum as well. And again, that's a very important function of the pancreas in digestion. It creates all these specialized enzymes whose job it is to further break down food. So they're going to be joining the bile in terms of putting its content in the duodenum. You've learned long ago that the small bowel has three parts. The most proximal part is the duodenum, as we've already said. Then the next part, and I'm just going to color here, and I'm just going to go, maybe somewhere along in here, that we're going to call the jejunum. And then, lastly, and we'll go this color here, the last part we'll just call along in here, that is going to be called the ileum. So I have three parts of the small bowel. I have a very short duodenum, then I have a jejunum, and then I have the ileum. The ileum actually is going to be interfacing or is going to be delivering the contents into the large intestine. And part of the large intestine is going to be colon. And so we have three parts of the colon, I'll just briefly say here. So you have the ascending colon. It's called ascending because the food is going from that area right there, from the ileum, into the large bowel. Here's a little appendix there at the very end of the ascending colon. So we're going to say ascending colon because it's going up in terms of food. And then the food then transverses the body, which is why we call this the transverse colon. And we'll go a different color here. We'll say right there, transverse colon. And then lastly, we will have the descending colon, where food is going down. And then ultimately the rectum and so forth. So that's our basic lay of the land here. I'm going to add a few other things in this diagram as we move along, but this should give you a sense as I allude to various parts of the digestive system where things are. All right, so now that we have that little bit of business taken care of, let's go back to what we were talking about here. Because we had last spoken of bile, again, being pushed into the duodenum via the ducts that are going to lead to your gallbladder. All right, so the next thing we want to talk about is going to be color of vomit. And that actually is diagnostically fairly important. Because as a healthcare worker, when someone vomits, you want to take a look because the color of the vomit actually gives you clues as to what's happening in your patient. Well, let me state the obvious, which is whatever you've been eating lately is going to go a long way in determining the color of vomit. So if you have eaten a pint of chocolate ice cream and then you vomit, then obviously the vomit is going to have a brown color. If you've eaten a large bowl of cherry jello and you vomit, obviously there's going to be red in the vomit. So that's the first thing you have to factor in is what has the patient been eating? Because that's going to go a long ways in terms of the color of the vomit. But what are some of the other things that we want to note? Well, sometimes when someone vomits, the vomit comes out and it turns out to be very white, foamy vomit. If you have white, foamy vomit, what that typically means is there's no food, unless you've been eating vanilla ice cream, of course. But aside from that, white foamy vomit means no food, so what have you been vomiting up? Well, what you've been vomiting up basically is acid, mucus, and saliva. And when you have that mixture content, it's going to come out very white and foamy, and it's not something to be worried about. It's not creepy. So it's really quite normal for it to have white foamy vomit if there's just very little food in the stomach. And so basically you're vomiting out acid, saliva, and some mucus. Vomit with red streaks. Again, assuming we're not talking cherry jello, red streaks would indicate fresh blood, which is never a good sign. I mean, somewhere in your GI tract, you have some type of hemorrhaging, and of course, it's coming out in the form of vomit. And the medical term for that would be hematemesis. Okay, the heme meaning blood, of course, emesis, of course, meaning vomit. So obviously, if the patient has red streaks in the vomit, then you've got something else to consider as you are working through your process of trying to figure out what's going on with your patient. Sometimes vomit can be orange. In fact, a lot of times it can be orange. Orange vomit itself is nothing to be greatly concerned about because with everything else being equal, an orangish look is kind of a normal color for partially digested food. So again, nothing great to be concerned about. Now, if the patient is vomiting or the contents of the vomit is yellow to green, well, now we're back to bile. And again, the bile may or may not be of a concern. So if someone has, say, an empty stomach and they just happen to have some bile reflux, and again, going back to our little cartoon here, now we can see it. So bile reflux would mean that I'm having some bile coming from the gallbladder here, and it's actually going backwards into the stomach. And again, if it's minor, that's not that uncommon. Now, if it's a lot, then that is suggesting several other things here that we'll talk about a little later. But one of the things, and again, we'll address this in more detail in a minute, is bowel obstruction. So if you have some type of obstruction in the small bowel that is not allowing food contents to go through its normal track, then what you're going to have is reflux from the duodenum back into the stomach through the pyloric valve. And so a lot of times that could indicate either bowel obstruction or if you have paresis or paralysis of the smooth muscles of the small bowel, where they're not undergoing their normal contraction, propelling the GI contents onward, that could also create a situation where you would have some reflux from the duodenum back into the stomach through the pyloric valve. So again, it's a matter of how much green is going on with that. And again, we're going to talk a little bit later about certain types of vomit events will actually force the content of the duodenum back into the stomach, but that's for another time. So anyway, yellow to green, bowel. All right, so the other one is going to be brown vomit. Now again, we're excluding chocolate ice cream on this one. So if you have, or the patient has brown vomit, you've got two basic things you want to think about. One is brown vomit could be the presence of oxidized blood. Which is basically another way of saying digested blood. Because the acid is going to digest blood and it's going to oxidize it, and when it does, it turns a brown to black color. So we'll go brown to black. So it could come out just looking black. So if you have that, one of the things to consider again would be, again, a GI problem in terms of bleeding. Now, I want to make a distinction between this and what we talked about earlier with fresh blood. And I used fresh intentionally because if it's a fresh blood, obviously a fresh bleed. But if it is brown to black, then that means ever how the blood got into the stomach, it's been there long enough to be digested. Now, one of the things that you want to look for if the vomit is a black to brown look is to look at the texture. Because if it is, in fact, digested blood, then this brown to black vomit is going to look like coffee grounds. In fact, medically, it would be called coffee ground emesis. And that just simply means you have old blood getting in your GI tract, don't know where it came from. That's your job as a physician or a medical worker to figure out. But that your stomach is digesting blood, comes out in the vomit, and it looks like the person has been eating coffee grounds. So that's one possibility for brown vomit. The other possibility for brown vomit is going to be fecal vomit. And it is exactly as the name implies. You're literally vomiting fecal matter out your mouth. It goes by several names. Again, fecal vomit be one. Another would be copremesis, another medical term for that. Another would be feculent vomiting or feculent vomiting. Or feculent emesis. And another term would be stercoraceous vomiting. Whoops, messed that piece of it up. Stercoraceous vomiting. Okay, again, some medical terms for the same thing. All right, so now you're asking, how is this possible? If the patient is literally vomiting feces, then the odds-on favorite as to why that is the case is that they have a lower bowel obstruction. So let's go back to our diagram here. Lower bowel as probably some type of obstruction in the ileum area. So if you have an obstruction somewhere in here, not allowing the contents to go through its normal process, that then is going to be causing significant reflux back the other way. So it would be going back through the ileum, through the jejunum, back into the duodenum, through the pyloric valve, back into the stomach. If you have an obstruction in the jejunum, or if you have obstruction in the early, if you have an obstruction in the early jejunum or the duodenum, then that is not going to end up with fecal vomiting, because the contents we would not classify as fecal at that point. But by the time you get to the ileum, it more has that, shall we say, attribute of feces, and that's in fact what would be coming out. Now, one of the things that you do have to assess when the patient is, again, vomiting, and if it is brown, one, does it look like coffee grounds? Well, no. Two, have they been eating chocolate ice cream? But the other is smelling it. If it smells like feces, then you know it's fecal vomit. That would be, again, the fecal vomiting, the feculent vomiting, would in all likelihood, again, indicate a lower bowel obstruction, but that's not the only thing that could cause it. Other things that could cause it would be some abdominal cancers. Okay, that's a possibility. Another cause, rare, but it can happen, would be if the patient has a gastrojejunal colic fistula. I'll spell that out for you. Okay, and the name tells you. Gastro, well, gastro is gastro. Jejuno, we're talking now that middle part of the small intestines. Colic, meaning colon. And then, of course, fistula. I think you understand fistula is a medical term denoting any type of abnormal connection between two hollow organs in the body cavity. So what this literally means, going back to my drawing here, is that I have an abnormal connection between the jejunum and the colon, allowing things to go from the colon into the jejunum and then back into the stomach itself. This situation here is usually tied to some surgical procedure. Patient would have had some kind of abdominal surgery, and as a result of that, a fistula was created, and then you have the reflux, or the backward movement of the content. Again, obviously fairly rare. So take-home point on this is that if the patient is experiencing fecal vomiting, odds are we're talking about some type of obstruction in the more distal regions of the small bowel. Okay, so I think that's all I want to talk about on this block, and we will continue next time with our next topic.